everybody. Welcome to the HEI webinar series. We're going to begin now. So just some housekeeping announcements before we get started. All attendees are muted for the duration of the webinar. There will be a 3-minute Q&A period after each speaker, reserved for short technical questions, and then in-depth questions will be reserved for the 50-minute panel discussion at the end of the session. You'll see a Q&A box on the bottom of your screen. Please submit any questions via the Q&A function. If you experience any logistical difficulties, please contact us using the chat box. All webinar slides and the video will be available on our website. And you'll also see a pop-up for a survey. Please fill that out. We really value your feedback about these webinars. And registration information for upcoming webinars is on our website. So the title of our session today is From Evidence to Action, Synthesizing Air Quality Evidence Relevant to Public Health. I'm Anna Rozovsky. I'm a staff scientist here at HEI. So our chairs today are Dr. Neil Pearce and Dr. Jennifer Peel. Dr. Pearce is a member of the HEI Research Committee and Professor of Epidemiology and Biostatistics at the London School of Hygiene and Tropical Medicine. Dr. Pearce's research focuses on epidemiological and biostatistical methods and their application to studies of non-communicable disease, including occupational and environmental health. He is a fellow of the Royal Society of New Zealand and the Academy of Medical Sciences and the past president of the International Epidemiological Association. Dr. Jennifer Peel is a member of the HEI Review Committee and professor of epidemiology at Colorado State University and the Colorado School of Public Health. She's an environmental epidemiologist with a focus on evaluating the health effects of ambient air pollution in the US and household air pollution from indoor cook stoves in lower and middle income countries. She has worked with the US EPA on integrated health assessments for criteria ambient air pollutants and is a standing member of a review study section of the National Institutes of Health and an associate editor for environmental health perspectives. Our speakers today are Strife, Dorota Jarasinska, and David Savitz, and our panelists today are Jason Sachs, Susan Norris, and Jonathan Samet. Here's our agenda today. I'm giving my opening remarks now. Dr. Peel is going to give a brief introduction, and then we're going to go into our speakers and the panel discussion. And so Jennifer, I'm going to hand it over to you now.
Thank you, Anna. Okay, so thank you, Anna, again, and I believe you should be seeing my slides at this point.
We do, yep.
Okay, so are my slides advancing? My computer, of course, just froze. I can, if you're not able to see my slides.
They are advancing and we could see
okay.
them. Yeah.
Perfect. I was tasked today with providing some context and the scope for the session today. Today we will be talking about evidence synthesis. This is obviously a discipline, an approach that is used across scientific disciplines. There are numerous methods that are used, and we'll hear about several of these approaches that are used in evidence synthesis. They include some of the ones listed here. Where they start to differ in terms of their approaches include areas such as how they evaluate the strength of the evidence from both observational and experimental study designs, especially with randomized trials, and as well as in terms of how they approach evaluating the quality of evidence. And this is obviously interlinked with the study designs that were mentioned earlier. So we wanted to, given this broad question and this broad topic of evidence synthesis, we did want to provide a little bit more context in terms of what we will cover today in the session. We will be focusing today on environmental epidemiology, as well as focusing on air pollution and health specifically. Both environmental epidemiology and air pollution and health have unique considerations in terms of where we may be able to gather the evidence from, obtain evidence in terms of study designs. As we were discussing the scope of this session, we were asked to contemplate the question, what is air pollution? I'm wondering if the session organizers wondered where we were headed with this session, but of course, this question by Dr. John Samet was an insightful one to help us clearly define our scope that we're covering here. We clearly can't cover all of environmental epidemiology or air pollution, even with air quality guidelines. But the focus today will be on air pollution and health and how evidence synthesis is used in criteria air pollutants in terms of considering the evidence. And when we talk about in the US, especially we use this framework of criteria air pollutants. These include topics such as particulate matter, ozone, oxides of nitrogen and sulfur, carbon monoxide and lead, as well as more recently some of the other components of particulate matter, including black carbon, ultrafine particles. And then as well, we use the same approach with air toxics, of course. So we are reminded by our colleagues in this panel, Neil Pearce has published broadly on this topic of evidence synthesis. And I thought a commentary, one of his recent commentaries was particularly insightful to think about in terms of evidence synthesis. It used to be a given that to decide whether a particular factor can cause a particular disease, one should consider reasonably cogent evidence. But this approach is being increasingly challenged both scientifically and politically. So just a reminder that we have to consider this topic in terms of both our scientific and political context these days. We were also reminded in this commentary that air pollution epidemiology is not necessarily unique in that we may not be able to always provide evidence from experimental study designs. And we see that in other areas of science as well, including the question about whether parachute use is effective in preventing death and major trauma when jumping from an aircraft. We're reminded that perhaps we may not need to have experimental evidence in order to consider that question. And in closing, as we can move on to our speakers, another insightful quote from another one of our panelists today, David Savitz and Greg Wallenius from their textbook remind us that the evaluation itself is useful in terms of integrating evidence, even if we are not able to come to definitive conclusions. So with that, I can turn it over to my colleague Neil Pearce to introduce our speakers.
Thanks, Jennifer. So we're starting with our three main speakers. We've got 20 minutes for each, but we'll ask the speakers to speak for 17 minutes. And then if we have time, we'll have maybe one key question, and we'll save other questions until the discussion after the comments from the panel. So our first speaker is Kurt Strife. Kurt was long-standing head of the section of evidence synthesis and classification at IARC in Lyon, where he directed the programs of the IARC monographs, the IARC handbooks of cancer prevention, and the WHO classification of tumours. Since his retirement, he is an associate researcher at IS Global in Barcelona and a visiting professor at Boston College. He studied medicine, epidemiology, public health, and philosophy in Europe and the United States. So it's with great pleasure I'll hand over to Kurt for the first talk.
Yeah, I'm not seeing that option that I've seen before.
So Kurt, at the top of your screen, there should be display settings. If you click on that.
No, that's exactly what I'm looking for, but I can't see it. Let me get out of that mode and let me do it differently.
Otherwise, this is probably okay.
Yeah, no, that's.
I think we can. I think we can see it all right. If
Okay.
Yeah.
Sorry for these technical issues. We have just tested all of that a couple of minutes ago, but looks different now. Okay. Thank you, Neil, for your kind introduction. And my topic today is evolution of and current issues in evidence synthesis and integration. And the organizers also added as introduced on the focus on air pollution and health. Last week's webinar of the Health Effects Institute, we have seen Tess Marsha presenting 7 hypotheses regarding global variations of COVID-19, from the climate hypothesis to the H hypothesis. And later, Paul Villeneuve raised methodological issues on interpretation of studies on COVID-19 and air pollution. So the question always is, in environmental epidemiology and in public health, how can we decide what is true, what we know? But instead of looking into the recent update of the WHO air quality guidelines or the US EPA, here we have, in fact, better experts with us today, Dorota Jarasinska and Jason Sachs. I have decided to take a broader approach on the history of causal inference, very briefly, and then on recent problematic developments, and from there deduce principles of evidence synthesis as currently proposed. So the short history of causal inference is that causation cannot be observed directly. Philosophers have developed constructs and heuristics to define a cause operationally, and these constructs typically have 2 components, an associational one and an explanatory one, based on proposed underlying mechanisms. For biomedical research specifically, the first criteria came following the discovery of bacteria during the 19th century, and when the germ theory kind of won the competition against the miasma theory. A method was needed for judging if an organism caused a particular disease, and that's when the Henle-Koch postulates were developed, and the Bacillus anthracis causing anthrax by Robert Koch was the final victory of the germ theory over the miasma theory. Here you can see the specific Henle-Koch postulates as they apply to infectious disease causation. However, in non-communicable chronic diseases, we typically have multiple causes, we have heterogeneous clinical features, and the much longer induction periods than in infectious diseases. This is where Bradford Hill developed the guidelines or viewpoints on how to bring indisputable evidence for or against cause and effect hypothesis. And his clear bottom line summary was that none of these viewpoints can be seen as required or as sine qua non. These are in support of causal explanations or as evidence against, that is, competing non-causal explanations. Here we have chance, selection bias, errors in measurements of exposure, confounders or outcome, and also residual or unmeasured confounding. You see the well-known Bradford Hill viewpoints on the left, from 1 to 9, strengths of the association to analogy. Those listed here in red are those that have also been used by the Surgeon General report. So there is a good overlap in terms of these viewpoints. And in fact, some of these would apply even to assessment of the validity of an individual epidemiological study, like the strengths of the evidence, the temporality. Some would apply to kind of synthesis across epidemiological studies, such as consistency, while yet others would apply to the evidence integration across different streams of evidence, such as the plausibility. This is what developed in the mid-60s in the question on if tobacco smoke causes lung cancer, and was followed by systematic reviews and concepts of causal inference, for example, as developed by the IARC monographs. And these have matured as an authoritative reference, for example, in cancer hazard identification, even well before the current risk assessment paradigms evolved. But more recently, there are approaches that were originally developed in clinical medicine, such as by Cochrane Collaboration or by GRADE, that now try to impose their methodology on evidence synthesis in public health. However, there's problems with just extending this clinical medicine methodology to environmental epidemiology and public health. And as Susan Norris, who is with us today as a panelist, wrote that these methods as developed by GRADE are currently not applicable to many questions that guide developers face, particularly those assessing risk and causality, establishing risk thresholds, or assessing animal studies. In addition, they have low inter-rater reliability when assessing complex bodies of evidence. From there, we go into the question of the study hierarchy, which is intricately linked to the question of risk of bias, and where randomized controlled trials are rarely used in natural sciences, such as physics, and for most important public health questions, e.g. global climate change, tobacco smoking, etc. On the other side, observational studies have the potential to suffer from biases that can be theoretically avoided by randomized controlled trials. From there, GRADE states that evidence from randomized controlled trials starts at high quality, and because of residual confounding that includes observational data, these start at low quality. So RCTs, in my opinion, may be a useful theoretical starting point to think about potential bias, but they do not provide the gold standard for environmental studies. Why is that? RCTs typically involve limited sample size and a short follow-up time, inadequate for observing chronic disease or rare outcomes. Observational studies often involve rare outcomes with long latency, even further complicating the limitations of RCTs. RCTs typically deliver the exposure, say the medication, at the beginning of follow-up, and typically in a limited number of dose levels. Yet in real life, exposures are often present before follow-up begins and occur at many different levels and often change over time. Further on, RCTs may involve highly selected study groups which have little generalizability to other populations. Within this framework of study hierarchy and randomized controlled trials versus observational studies, an important tool that comes in is the risk of bias tools. And there is an increasing use of various tools for evaluating epidemiological studies, such as the Robbins family, or tools proposed within the GRADE framework. Typically, these risk of bias tools focus on whether specific biases, e.g. Selection bias, information bias, are present, but typically they do not assess the direction, the magnitude, or the overall importance of the various types of biases. We need to know, of course, that information bias would be unlikely to explain positive findings of studies if there is non-differential exposure misclassification. So this is not taken into account by these risk of bias tools that don't look into direction or magnitude of the bias. Further, risk of bias tools typically evaluate bias in individual studies and consider individual studies out of context. And altogether, these risk of bias tools are often used to exclude so-called low quality studies from the evidence synthesis. This is one example were in fact a set of risk of bias tools was investigated by Stephanie Ake and Nick Schacht and Tracy Woodruff, comparing different risk of bias tools and with regards to their usability and also with regards to the inter-rater reliability on human observational studies. I'll focus on the inter-rater reliability, and but also would want to mention that even a high reliability would not necessarily guarantee a construct validity of what's being assessed. And you can see this from one example from their paper. This is one of the risk of bias tools that had been used by the TOSCA framework. And this had a moderate inter-rater reliability of some 54%. But if it comes to the less granular, but the overall assessment of the studies, all studies were judged as inadequate. So there was a very good inter-rater reliability, and all studies were excluded from the evidence synthesis. Why was that? This one last, second to last column is about statistical power. And if the study didn't explicitly report about the power calculation, then this was deemed as inadequate, and the study was rated as altogether inadequate and critically deficient. So you can see here that a high inter-rater reliability is not necessarily a good idea. Of course, a necessary, but in no way sufficient way to assess these different risk of bias tools. Let's go on with the risk of bias tools. Here you can see the family of risk of bias tools on intervention studies, randomized intervention studies, or non-randomized intervention studies, or in yellow here, studies on exposure. These would be the typical analytical epidemiological studies that we use in environmental epidemiology. Now, the one strong advantage of the Robbins E, which is still in development, is that the experts who started to develop the Robbins E wanted to have feedback from experts in the domain of environmental epidemiology. And this is very much appreciated because unfortunately that subject matter expertise is not often taken into account. However, when several of these senior epidemiologists got involved, there was a lot of concern, and that was published in a commentary in Environmental Health Perspectives by Carl Steenland et al. This is again about randomized controlled trials that may provide a useful starting point, but shouldn't be seen as a gold standard for environmental studies. And rather than having a checklist approach when evaluating individual studies, the authors call for identifying and quantifying possible biases and their direction and their impacts on parameter estimates. So as recognized in many guidelines, evidence synthesis requires a broader approach than simply evaluating risks of bias in individual studies, followed by synthesis of studies judged to be unbiased. I'll skip study informativeness, which is a kind of complement to the risk of bias. This has been introduced in the latest updates by the report on carcinogen, but also by the updated IR preamble. We can discuss this if there's interest in that. I'll move on to conflicts of interest, another issue in evidence synthesis. And this is an issue at the level of the development of frameworks for systematic review, but also at the level of the assessment of individual agents or individual studies. So one of the risk of bias tools, for example, says a definitively low risk study, an ideal study would be if authors state that there are no conflicts of interest or that the funders did not have a say in the methods, analysis, and reporting of results. Now, unfortunately, we know that this is often easily stated and not always true. So I think this is a very naive approach to conflicts of interest. And if you want, I can provide several strong examples. At the level of assessment of individual studies, it starts with which evidence is published at all so that it can be taken into account in evidence synthesis. And now a bit closer to air pollution, there is the example where industry groups threatened the US NCI and NIOSH to publish their study on diesel engine exhaust. And so with this very strong and possibly influential study would not have been available for assessment. But there is also, after the publication, withdrawal of accepted studies after takeover of journals by stakeholders with vested interest. And in that whole context, we have the problem that there is relatively weak conflict of interest procedures. And this also extends to the weakness of the Committee on Publication Ethics, COPE. All of that brought together in one example that is now a bit further from air pollution and environmental epidemiology, but is also environmental epidemiology in the broadest sense, is when IARC, the monographs, assessed the carcinogenicity of processed meat and classified these as group 1 carcinogenic to humans. It was just this morning when I prepared this presentation that I got one of these spam emails from ResearchGate that this has now been cited read more than 5,000 times. However, quickly after the publication of this evaluation, there was an editorial in Financial Times by Gordon Guyat, who concluded that there was a false alarm on red meat and cancer. And he concluded that there were 2 large trials that have tested for evidence, and IARC ignored both of them. And instead, IARC, WHO, leaned heavily on the third source, epidemiological data, just to finally conclude that unless relative risks are greater than 5, epidemiological studies typically provide only low quality of evidence. So you see here the false hierarchy of study design and false cutoff points in terms of strengths of association, underestimating and downgrading observational epidemiological studies. 4 years later, after this editorial in Financial Times, he published with a group of scientists a systematic review and meta-analysis of cohort studies, and also followed by guidelines for unprocessed meat and processed meat consumption. And soon after this publication, there was a storm of comments, including prominently published by Harvard School of Public Health and also by the World Cancer Research Fund, essentially stating that the new guidelines say continue red meat consumption habits, but recommendations contradict the evidence. In addition, as pointed out by the BMJ, these guidelines were also undermined by undisclosed ties and faulty methods. So you see several of the issues that I had mentioned before coming together in this one slide. I'll save some extra time and don't go into the details of the problems of these meta-analysis, again, for discussion if there's interest, and want to conclude from these problems, and I've had time only to highlight a few of the problems in the current kind of developments, the idea to develop principles of evidence synthesis, and this is done by a task group at the International Society of Environmental Epidemiology. These have not yet been finalized. These are in current evolution, but I summarize here and on my final next slide what is seen as important principles of evidence synthesis that would also apply to environmental air pollution epidemiology. You would need strong subject matter expertise covering the different aspects and perspectives of expertise involved in systematic review. The systematic review methodology and the expert reasoning should be documented and made transparent. And there is the need for for proper and transparent management of real and perceived conflicts of interest, from the protocol development to the peer review and handling by the editor. As recommended by the National Academy of Sciences, financial conflicts of interest should be a risk of bias evaluated in the primary studies used in the systematic review. The inclusion of pertinent studies should be comprehensive, with all studies based on the scientific merit, as opposed to outright exclusion of studies on the basis of selected attributes. Further, as recommended by the NAS, ROP tools that use a domain-based approach should be used, and they should not be too prescriptive to evaluate the internal validity of a study. The evidence synthesis should start by listing all the possible biases in a structured approach, and then for each possible bias, consider the available evidence can inform the strengths, direction, and potential bias of its impact. Possible biases should be assessed by other approaches also, e.g. the triangulation approach, and I'm sure Neil Pearce will talk a bit about that. And all of that together in terms of meta-analysis, these also need to be critically assessed, similar to individual studies, and do not necessarily provide higher certainty of the evidence. Thank you, and apologies if I've gone slightly over time.
Thanks very much, Kurt. So you're 2 minutes over time, so that's fine. Thanks for the very interesting presentation. I think if you can stop sharing your slides, we will move on to the next speaker and take more general questions at the end. So the next speaker is Dorota Jarasinska, who's a specialist in public health, working for nearly 30 years on health and environment issues. She's at the WHO European Centre for Environmental Health, where she manages the program that covers a diverse portfolio, including the health aspects of air quality and climate change mitigation, chemical safety, environmental noise, environmentally sustainable health systems, and occupational health. And currently she coordinates the project on updating the WHO Global Air Quality Guidelines. So I'll hand over to Dorota. Thank you.
Thank you very much, Neil. Hello, good day to the participants. Thank you also for inviting me to speak and to share some of the experiences from the practical application in the context of the development of air quality, WHO air quality guidelines. So let me start with a very brief reminder what the guidelines are, that these are robust public health oriented recommendations to protect population health from air pollution. As such, they are not legally binding standards, but have been extensively used as a reference point for setting national or regional level legal standards for air quality. They are meant to be applicable globally, and they are developed based on a comprehensive assessment of the evidence. And the first edition of the guidelines was released in 1987, and we are now about to finalize the update, which we initiated at the end of 2016. Of course, over time, the guidelines have been evolving. They have been evolving in response to the accumulated scientific evidence. They were also evolving, responding to how the guidelines were used, with some formulations, considerations of, for example, environmental equity, building a bit more extensively on the issues like importance of risk communication, introduction of interim targets, which were like a step in the process towards reaching the ambitions of air quality guideline values. And last but not least, and which is the essence of today's webinar, also the approaches to evaluating the evidence and developing guidelines as such have been evolving. And the current process is guided by the document Handbook for Guideline Developments, which sets very precisely the steps for planning, development, and then publication of the guidelines. And the issue of evaluating and grading evidence features prominently in the developmental stages, at the stage of producing systematic reviews and then formulating recommendations. Since we are almost there with the update of air quality guidelines, you may wish to get a sense of where we are in the process, working on the finalization of the draft of the document. So the guideline development process, in a nutshell, involves several groups with clearly defined roles and responsibilities, and just these 3 steps: systematic review of evidence, grading the evidence, and developing recommendations. But behind these few modestly looking bullet points, there is an immense effort of a big group of experts involved in the process, in the guideline development group, which is a core group responsible for formulating the recommendations, a systematic review team who took a responsibility for evaluating the evidence, and then a group of individual experts and stakeholders who were responsible for providing comments to the draft document, and finally the WHO team. This was an immense task because of the volume of the evidence to be reviewed and evaluated, but it was also huge because there were certain methodological challenges, of which we have already heard from Kurt as signaling. So how to grade the evidence that we had on board for the air quality guidelines, the evidence which is comprising vastly from the observational studies. And finally, a process of deriving the guideline values from the evidence. It was also an intense process requiring some methodological work. So throughout the process of updating the guidelines to accommodate and to address the challenges faced and to provide guidance to the systematic review team and to adhere to the demands and requirements of the process, experts involved developed a risk of bias instrument applicable for the systematic reviews that are informing the guidelines, and also a dedicated adaptation of the grade framework, of the framework used to grade the evidence being reviewed, and those are publicly available. We have already heard about the grade, the framework which is adopted by WHO. So this was the framework within which we have been operating, developed primarily for clinical guidelines and for interventions. It has, of course, a number of positives and the value which helps to enhance this, in principle, the comparability of the judgments when all who are assessing are considering the arguments underpinning in a similar manner. There is a description, identification of factors that can be considered for downgrading or upgrading the certainty. There is a rationale elaborated and made available for each of those factors, which ultimately helps to grade the evidence as high, moderate, low, or very low. And then this information is then picked up in the further steps of developing the guidelines. However, while this basic concepts and principles can be applied also for developing air quality guidelines, for guidelines focusing on environmental exposures, there is, of course, a number of challenges already signaled in the introductory words and by Kurt. This was the main driver to develop this adaptation, and this adaptation was developed and designed specifically to assess the certainty of the evidence for the systematic reviews which have been informing the guidelines. This adaptation is not focusing on assessing the strengths of evidence for causal inferences, but more to rate the certainty of the effect estimates. And it was designed and it was used by the team responsible for systematic reviews on how to use the grade criteria for the body of evidence colleagues were working on. This was a very extensive and demanding process involving sometimes very heated discussions. The concept presented and discussed at the meetings of the guideline development group, then pilot tested by the systematic review team, then improved in an iterative manner. And this great adaptation concluded with the following statement, so that the rating of the certainty of the evidence for observational studies was positioned as moderate certainty evidence, and for all conditions, reasons for downgrading and for upgrading, a rationale and a guidance was provided with an indication of, in the case of downgrading by 1 or 2 levels and upgrading only for 1 level in case of large magnitude of effect size, concentration response gradient, and when all plausible confounding was shifting the relative risks toward the null. This great adaptation has been applied and is reflected in the systematic reviews of evidence. This effort of developing the great adaptation for the purpose of the work on the air quality guidelines, of course, revealed the existing challenges and also pointed out to things which still require further work. And I believe that the discussion at the fora like today's webinar are contributing to it, is the question of this golden standard of randomized trials. In this case, a concept of this random assignment of exposure, while conceptually useful and compelling, effectively largely unachievable in practice and not applicable for the bulk of the studies that form the body of evidence considered. This discussion on the adaptation of grade revealed also an issue of different concepts, definitions, and also different quality expectations for the same things in different expert communities, even for the very concept of exposure assessment and the quality assessment of exposure in the communities like epidemiology and exposure science community. These differences are posing some issues, potential misunderstandings. Again, raising a question whether a single golden standard could be considered or whether more fit for purpose standards might be considered. In case of the topic of air pollution and health and the evidence considered for air quality guidelines, in this domain, the evidence, of course, comes from different lines of research. And then again, application of the framework to grade the evidence coming from these different lines of research, epidemiology, toxicology, in vitro studies, etc., remains a challenge. And I believe we will hear more also from the experiences of the US EPA. And also a pragmatic point that in this very intense project of developing the update of WHO air quality guidelines, this substantial chunk of methodological work to develop risk of bias tool, to develop the great adaptation for the purpose of the guidelines, really added quite a big task, and combining the process of implementing the project with some methodological developments was quite demanding, and was possible only through a huge dedication of the experts involved. Speaking about this great adaptation for the guidelines, I want to stress that it's not meant as a robust, great adaptation for environment and health studies. It has been tailor-made to serve the purpose of being a guidance for the team conducting systematic reviews for the guidelines. And it was really a useful guidance. It described and elaborated on the rationale agreed, proposed by the experts, and is also giving certain level of transparency of what were the criteria, what were the decisions made in this process. So finally, we have now the systematic reviews published. They are available in the special issue of Environment International, and this includes also this description and elaboration of this great adaptation. A risk of bias instrument is also available on the WHO website. But to conclude, let me just update you where we are with the very document. So the scope of the work on the update of air quality guidelines was the following. It's to develop recommendations expressed as numerical concentration values and, where possible, shapes of concentration response functions for the listed pollutants, for averaging, relevant averaging times, and in relation to critical health outcomes identified by the GDG. Then to develop a qualitative recommendation or a statement on desert dust, develop recommendations for particulate matter components and ultrafine particles if feasible, and then to propose interim targets to support monitoring and implementation. So with this plan, we have now a draft document where these recommendations, new revised guideline values have been proposed, and they are revised and the values differ from those that were published in 2005. The interim targets are retained in this upcoming update of the guidelines, and new values are added. And for the topics of desert dust, ultrafine particles, and black carbon, the document contains so-called good practice statements. these issues were subject of very intensive discussions also among the GDG, with input from external experts working on those topics. However, it was concluded that it's not feasible to develop guideline values for those. However, I would say a step towards it is the inclusion of the good practice statements for those. And we hope that with the next update of the guidelines, at least for some, we may be closer to formulating the guideline value.
You have 1 minute.
And in this 1 minute, I can only say that we are working towards releasing the guidelines by the summer holidays. The exact date has not yet been fixed, as we are working on finalization of the draft. However, we are heading at the end of June and the beginning of July. And as soon as the date is fixed, we will, of course, be happy to share this information, and hope we will meet at different fora when the guidelines will be presented and hopefully then implemented. Thank you very much for your attention.
Thank you, Dorota. So we're starting to get questions, but we're still trying to keep to time. So I think we'll move to the next speaker and then bring up the questions during the discussion. So thank you very much for an excellent presentation. And I'd now like to introduce David Savitz, who I'm sure all of you will know. David is chair of the HEI Research Committee, professor and chair of epidemiology at Brown University School of Public Health, and his epidemiological research has addressed environmental hazards in the workplace and community, reproductive health outcomes, and environmental influences on cancer. He came to Brown University in 2010 from Mount Sinai School of Medicine, where he had served as the Director of Disease Prevention and the Public Health Institute. So, David.
Thank you, Neil. Let me get my slides and okay, I will assume it's working unless somebody stops me and tells me that it's not. First, thanks to the organizers of the session and the chairs. It's a topic that I've become increasingly interested in. I'm convinced that among the many challenges in the application of epidemiology to policy, that in addition, of course, to the basic knowledge that we start from, the ways in which we use it and integrate it is I think increasingly recognized as essential and important and insufficiently developed. So again, I've given the maybe somewhat provocative title of acknowledging that evidence is incomplete. It's not conclusive, of course, but nonetheless should be used for what value it provides, and it does provide value. So in trying to think about this, I obviously know well the world of academic epidemiology, but I've increasingly, through HEI in particular, been exposed to the perspective of policymakers. And the goal, of course, is to make the optimal use of the best available evidence, not overstating its quality or understating it, but sort of getting it right. And to really think more about this pathway for what I would term demand-driven epidemiology. Epidemiologists often think we know what policymakers need, but it's often a bit of a naive view that we can tell them what they need. I think we need to hear from those who are in positions at agencies and industry and so on to hear about what kinds of information would be most important. And that's, again, something that the Health Effects Institute has really made into a sort of a fine art, if you will, of connecting the academic and policy worlds. It's also a recognition that ultimately the assessment and judgments are in fact judgments. They're informed judgments. I always cringe a little when someone says, "Oh, the science dictates this." Science doesn't dictate, it informs, and then judgments have to be made. And so I think acknowledging that is important on both sides. It allows the researchers to be more honest in evaluating strengths and limitations, And I think it allows policymakers to recognize and accept that they have a very important role in making thoughtful judgments at the end. So in this, in my hypothetical alternative universe that has a policy without controversy, and it clearly is an alternative universe, it would result if we could apply predefined structured algorithms to judge the available research. So it would be objective, replicable, universally accepted. We would judge study quality using standard, again, well-accepted criteria. We would put it in quality bins. People seem to like to bin this sort of information into the, the best studies, the medium quality studies, the poor studies, and so on. And it would be done without controversy or ambiguity. And then finally, we would end up with this integrated interpretation. Does it support a causal effect of exposure at the specified levels? Does it identify a threshold for adverse health effects, which of course is ultimately what's needed to make a judgment about a cut point for setting policy? So, I mean, Kurt touched on some of this, but in talking about observational studies and causal inference, first I'll acknowledge that research generates measures of association. That's the product of the research. But it is only the only purpose in doing that is to try to approximate the causal effect. Sometimes epidemiologists like to sort of hide behind the fact, oh, it's just an association. Well, if it's just a statistical association, it really isn't very interesting or useful. The question is how well that statistical association approximates the actual causal impact. And making that judgment requires expertise in both epidemiologic methods and deep expertise in the subject matter regarding, in the case of air pollution, really understanding the nature, sources, characteristics of exposure, subtleties related to the health outcome, and of course, the potential confounders that can affect that. And at the end, when we're making this assessment of the, trying to compare the measure of association with the causal effect, it's a continuum of certainty. We don't declare it valid or invalid. It has a number of considerations that bear on its validity. So in trying to think about more maybe attainable goals for epidemiology, I think that certainly we are obligated and able to provide a comprehensive and accurate description of what has been done. I think that even before we look at the results, we can look at the methods and make an evaluation of how good the research is, how susceptible it is to biases. And the reason I say that is it isn't a matter of whether we like the results or not. We can judge quality should be driven by methods alone. So that whatever the results are, that's not that determines the implication, but it doesn't characterize the quality. One of the key elements is relating the study results to the methods that were used, and I'll come back to this in a little bit more detail. The next step was to integrate and interpret the epidemiologic evidence. And I think another aspect of this that's probably underemphasized is how to communicate the product of that clearly. I'm convinced that some of the simplistic algorithms are appealing because it seems like the bottom line is so clear. And when we start to accept a continuum of evidence and uncertainty and degrees, it becomes a bit more murky. And I think we need to work harder at communicating murky evidence accurately, and that's often what we have to work with. And finally, after the epidemiology has been well characterized, then it's the integration with other disciplines in the form of triangulation across lines of evidence. And I am a believer in epidemiologists not trying to be the ultimate integrators. The epidemiology isn't better or worse because the mechanistic evidence is there or not. The epidemiology is good or bad on its own terms, and the final judgment, of course, should be influenced by the degree to which it's supported or refuted by the mechanistic evidence. In the inherent nature of how epidemiology works, I think of it as each study is making an incremental contribution to the overall body of knowledge. It can build momentum or contradict other epidemiologic studies. The ultimate use and interpretation is influenced by these other lines of evidence. Sometimes people outside the field keep waiting for this sort of the definitive study, finally once and for all to put this to rest. And I think we should abandon that search. It's conceptually and logistically unattainable. And so the use of the evidence ultimately requires weaving together these imperfect studies. So in trying to characterize the quality, again, I said it's along a continuum and you have to consider all the different features, but the goal again is to look at the potential biases that can result in an over or underestimation of the causal effect. We're talking about a disparity between the measure of association and the causal effect, and of course that can go in either direction. The magnitude of that error is informed by prior studies, work within the study, sensitivity analyses, methodologic research. And what we can do with that then, as I've argued and others have pointed out, is look at the patterns. Is there a consistent pattern to the studies that measure exposure more effectively and less effectively, that are more or less effective in controlling confounding? And by looking at that pattern, we can make a judgment about how important or consequential the bias is. I often find too that we can start with a laundry list of concerns, but we ultimately end up with a rather small number of primary influences on validity. And it's interesting in air pollution epidemiology, and I know this is a gross oversimplification, but if I had to pick the top two, it's always going to include exposure assessment and confounding. Exposure assessment because air pollution is very, very hard to characterize, especially over long periods, and confounding because air pollution is far from randomly assigned in the population. And so for each of these, we would look at how effectively they measure exposure, how effectively they control confounding, and see whether there's a pattern that demonstrates the bias is or is not a problem within the range of what the literature offers. Obviously, if it is a problem, we need to zero in on the studies that have done a better job of handling it. If it's not a problem, we can relax and move on. And that's, I think, just as important as when we can provide reassurance through this comparison. So this assessment of validity, to maybe state the obvious, is nuanced and it really requires expert judgment. It's not a generic universal algorithm. It's not something that can be sort of managed by people who implement a protocol on its own. What it does, I think, is it informs the judgment. It isn't a substitute for the judgment that has to be made. And so again, the interpretation at the end, it doesn't, when I say nuanced and expert judgment, it doesn't mean that we can get away with just saying, trust me, I know what the answer is, but rather that it should be transparent, the logic should be explained carefully, reasoned, and it should be explained so fully that others could look at the same line of evidence and come to different judgments. Let me just mention now a couple of very specific themes. And one of the sort of issues I've been thinking about more, and I have a draft manuscript under review and looking at this, is this sort of gravitation to meta-analysis, pooled estimates, if you will, maybe I should say more specifically, pooled estimates as the ultimate product of evidence synthesis. And it's understandable that we would like to have this integrated quantitative product from body of research. It certainly makes intuitive sense that putting evidence from multiple studies together is better than looking at them in isolation in principle. But what's peculiar, it's always struck me as peculiar, it presumes that the results vary only due to random error and weights them by size. And of course, in epidemiologic studies, random error is sometimes, but not very often, at the top of the list of concerns. I've said in air pollution, I think the top two are typically exposure assessment and confounding. And again, as referring back to points Kurt made, this is not, the informativeness is not a direct function of the size. There's always the question that is debated about whether the studies are even sufficiently similar to combine them given the varying methods, and even a question of whether the universal measure, whether we think all studies should converge on the same estimate. They may be looking at a different range of exposure. There may be differing cofactors across populations. And so even if all of them are exactly right, they may not get the same answer. I think that pooled estimates can assist in assessing patterns. They can be part of an evaluation. But I think one of the biggest dangers is this illusion of certainty. When you say we have 40 studies, we look at the confidence limits on the pooled estimate, and it looks like we've zeroed in on the truth. And I think that in most cases, is false advertising. Another theme I'll be very brief on that Kurt had talked about in more detail is this issue of randomized trials and observational studies. And I think it appropriately is in the area of looking at healthcare interventions. I think the relative merits of randomized trials over observational studies can be quite clear for very discrete interventions, mainly because medical care is far from randomly allocated, and confounding by indication is a huge, in some cases, insurmountable challenge to observational studies, although the technology of observational epidemiology and healthcare has advanced considerably. Randomization is the only method to control confounding by unknown determinants of disease. That is true, and that's something that needs to be acknowledged. But in looking at environmental agents generally, including air pollution, it's very difficult to manipulate exposure. It's almost impossible to manipulate it over a long time period, which is often what we're interested in. And we often end up with a very modest contrast relative to the naturally occurring variation. This occurs too in also behavioral studies where they intervene to try to, let's say, change someone's exercise level, and they may be able to tweak it a little bit for a short period, but that's tiny compared to what people do on their own and the magnitude of variation. So again, susceptibility to confounding is a major concern in air pollution epidemiology and other areas, but it's a mistake to focus on it as though it were the only determinant of quality, because it's not. So again, going back to summarizing some of the distinct features in air pollution epidemiology, it really requires this integrated knowledge base on exposure assessment, the determinants of health outcome, and statistical methods, of course. The sources and levels are so variable that they argue against their finding the universal measure of effect based on a typical exposure metric. I'm sure, as this audience well knows, there are different particle constituents, and there are different contexts for the exposures that we study. Another feature that has to be recognized is we're often looking for a subtle effect of air pollution in the context of a much more powerful health determinants. Very often air pollution is related to socioeconomic status, and air pollution at the lower ranges may have a subtle effect. That's what we focus on. Socioeconomic factors have an overpoweringly large effect, and we're trying to isolate one from the other, which does make the issue of confounding problematic. Another point I think to recognize is that statistical precision doesn't equate to validity. There's sometimes this sense that as we've gone into studies with literally millions of people included in database studies, that it surely must be right. And I would say it must be precise, but that doesn't overcome the other limitations in causal inference that would apply. I think that, again, this is as a sort of a somewhat of an outsider, although I've learned a bit more, of course, about air pollution epidemiology of late. I don't know that there's a need to continue replicating the commonly used methods, but really to look for opportunities to triangulate novel settings, something that Neil Pearce has advocated for we may not need the 50th or the 100th study in North America or Europe, but maybe we need the 10th study in Africa. That would be an interesting way to go, or other settings in Latin America and so on, where there's been much less work. We may be able to learn some new things.
You have 1 minute.
Thank you. Study designs, certainly, again, there are different approaches to that, and drawing on other disciplines. So again, finally, last slide, there's the product of this synthesis is a volume of informative studies need to examine the key methodologic features, look at the relationship of methods to results, and really end up with a clearly communicated description of what we know, how certain we are, what we don't know, and try to relate that in a way that is helpful to those who formulate policy. Let me close with that and leave it for the discussion to get into some of the other issues. Thank you.
Thanks very much, David. We're just about right on time, and I think the questions we're getting are probably better answered by all of the speakers and panelists, so we'll move on. And I should say thank you for all the questions. Please keep them coming. We're particularly interested in questions on the general principles of evidence synthesis rather than getting too detailed in terms of what WHO is going to do next about specific regulations. But we'll come to those questions as well if we have time. But I'll hand over to Jennifer to chair the panel discussion. Thanks.
Thank you, Neil. And thank you to all the speakers. Hopefully my internet will hold out here as it's been going in and out. But it is my pleasure to introduce our panelists today. And our first panelist is Jason Sachs. Jason is a senior epidemiologist in the Center for Public Health and Environmental Assessment in the Office of Research and Development at the US EPA. Jason is the project lead for the particulate matter integrated science assessment and plays key leadership roles in synthesizing the health effects evidence of air pollution for various national ambient air quality standards reviews. So Jason, turn it over to you.
Thanks, Jen. I appreciate that introduction, and I'm happy to be here. I'm going to just give a couple opening remarks focusing on evidence synthesis and integration in the context of the integrated science assessments. I just need to display this disclaimer before I give my few remarks. So as I'm sure many of you are aware, the integrated science assessments represent a systematic evaluation and synthesis of the most policy relevant science, and they form the scientific basis of the review of the national ambient air quality standards. Within the documents, we're conducting a qualitative assessment to evaluate the causal nature of relationships between the criteria pollutants and health and welfare effects. We're using a weight of evidence approach and a 5-level hierarchy of assessing causality, where each level of that hierarchy is delineated by our ability to rule out with reasonable confidence chance confounding and other biases. We're also in the process of the integrated science assessments providing information on quantitative relationships where that is available. So within the documents, we're forming our broad science judgments or forming the causality determinations around broad health outcome categories. And by broad health outcome category, I mean cardiovascular effects broadly or respiratory effects. But within those categories, we are outlining where the strongest evidence is coming from. And so we're integrating evidence across the different scientific disciplines. And in that process, we're going through what we like to call triangulation, maybe a little bit different than the way others have conveyed it, but we're trying to see how those different lines of evidence fit together to ultimately form the causality determination. And in the process of evaluating the evidence, we're assessing consistency of effects within a discipline, coherence of effects across disciplines, and whether there's evidence of biological plausibility. We've detailed this information in a standalone document called the Preamble to the Integrated Science Assessments, and it goes into more detail, both the weight of evidence framework as well as the rationale behind each of the causality determinations. And so in the process of working on the ISAs, we've continuously evolved over time in our attempt to not only improve clarity, but also transparency in our assessment of the evidence. This started with first within the ISAs themselves, we had a separate section focusing on how we went about evaluating the science and the framework. This led to the development of the standalone preamble to the integrated science assessments. In recent ISAs, we've developed a table that outlines scientific considerations for each of the disciplines and what we think about in the process of evaluating individual study quality. And it ultimately led to, in the most recently completed ozone ISA, where we developed specific criteria, which we called PICO statements, which defined the scope of the literature that we were considering for inclusion within the document. And this also included a qualitative analysis of individual study quality for some of the selected outcomes or selected studies that we evaluated within the document. And so again, it's showing our evolution of the ISA over time. That's all that I wanted to mention.
Thank you, Jason. We will come back to these topics as we revisit for our panel discussion. And for now, we will move on to our next panelist. We have next Dr. Susan Norris. Dr. Norris has extensive experience with evidence appraisal and synthesis and with guideline development related to clinical medicine and public health. She was the secretary of the WHO Guidelines Review Committee for 8 years, where she was responsible for quality assurance and methods development. She has an MD, a Master's of Experimental Surgery, and an MPH. Susan, I will turn it over to you.
Thank you very much, Jennifer, and thank you for the privilege of commenting. Just make a couple of observations on comments on GRADE. GRADE, as we know, started in the clinical realm of clinical interventions. GRADE is really two parts. It's the certainty or quality assessment of a body of evidence, and it's a framework for evidence to decision-making for policies and recommendations. And it's important to distinguish those two because one may have issues with one part, for example, the certainty of evidence assessment, but don't ignore the fact that there is this other a whole piece of GRADE that may well be useful to you. GRADE was designed for interventions where RCTs or clinical interventions considered the gold standard. And it assesses the certainty of a body of evidence for an effect size, as Dorota stated. It does use an absolute standard. If RCTs are infeasible or unethical, GRADE doesn't raise the quality assessment of non-randomized studies. They're still low certainty. GRADE's made huge advancements in evidence synthesis and guideline processes over the last 20 years in terms of transparency, our standardization and consistency, use of terminology, this focus on certainty or quality of evidence at the individual outcome level rather than at the study level. The domains for assessing the body of evidence, I think, make a lot of sense. The upgrading and downgrading factors Dorota presented, and the evidence to decision framework moves beyond benefits and harms for decision making. But there are limitations in GRADE, both in what it was designed to do and in terms of what methods have been developed. So I'll just touch on an example of each of those. So the limitations in terms of what GRADE's designed to do, there are different types of questions that require different types of evidence and different approaches. Classic GRADE, as they say, is for intervention effects, where causality is usually assumed, and it's not intended for questions of risk or association or exploration of causality. So the application of GRADE for interventions where RCTs start as high quality shouldn't be misapplied to questions of risk or association or other types of questions. The only methods GRADE has on questions of risk or association relate to prognosis from a disease or condition. And here you don't have RCTs for such questions, although you could use the single arm of an RCT. And here in questions of prognosis, GRADE recommends starting at high certainty evidence and rating down according to various factors or limitations of the body of evidence. And I think that concept is extremely useful for application in questions of risk in environmental health. GRADE doesn't well address evidence integration, and that's been mentioned multiple times by our speakers. And this integration is required for questions of causality and environmental health. We need to look at diverse types of evidence across to address questions. We've seen problems with this recently in COVID for questions of aerosol spread or the use of masks, where there's criticism because the systematic reviews and guidelines have only used the RCT paradigm, ignoring other types of valid evidence. These questions require examination and integration of multiple streams of evidence across complex causal pathways, which GRADE does not do well. GRADE is starting to think about analytic frameworks, complexity of the systems in which interventions are delivered, and framing key questions beyond PICO, but they have a long way to go in that regard. So I'll just finish with what I think may be the way forward. We need to make clear distinctions between the types of questions that are being examined, intervention effect versus risk or association. And the RCT paradigm is not appropriate for all types of questions and situations, and GRADE doesn't state that it is. I think GRADE is often or can be misapplied for questions for which it was never intended. I think the guidance GRADE has on prognosis or risk for certain substrata, subpopulations may well be a useful model for application in questions of risk and environmental health. But then the evidence on risk or association needs to be combined, of course, as you all know well, with other streams of evidence to consider causality according to criteria such as Bradford-Hill. This is beyond the scope of GRADE, but it's not inconsistent with GRADE. GRADE needs to develop additional guidance on other types of questions, like establishing risk or thresholds along a continuum of exposure outcomes, as in targets for air pollution, for example. And finally, the fields such as environmental health need to continue to evolve and disseminate integrative methods such as triangulation and the incorporation of mechanistic evidence, physical properties, et cetera, to inform decision making. There needs different fields and approaches can learn from each other. And I think there's not been sufficient productive discussions across fields, and that's what's needed to move the evidence synthesis field forward in environmental health. Thank you very much.
Thank you, Susan. We have lots of questions coming in, so we'll move on to our final panel member, who's probably familiar to many of you, Jonathan Samet. Dr. Samet is a pulmonary physician and epidemiologist and is the Dean of the Colorado School of Public Health. His research focuses on the health risks of inhaled pollutants in outdoor and air and also indoor air pollutants, including secondhand smoke and radon. He has served on and chaired numerous committees concerned with the environment, tobacco control, and health. Currently, he leads the Colorado COVID-19 modeling group, which is modeling the epidemic in Colorado for public health purposes. And he was elected to the National Academy of Medicine in 1997 and received the David Rahl Medal in 2015 for his contributions. John, I'll turn it over to you.
Thanks, Jen. And good morning, all. So I've got a few things to say. This has been really interesting. So I think this is alluded to. I think the conceptual problem we're dealing with here, how do we know what we know, is hardly new. And the use of epidemiological evidence to identify advances in knowledge, the problems of doing that are not new. I think one only need to go back to the 1950s as the evidence emerged on tobacco smoking and the causation of lung cancer and other diseases. I would recommend a start at the 1964 Surgeon General's report. Of course, the challenge now of air pollution epidemiology is that we have more and more studies, in fact, by the thousands, and capturing what increments of knowledge they may contain is increasingly challenging. And we've turned to more systematic methods to identify those studies and glean from them what they may be telling us. It's just a thought experiment. Think about changing a method in a process and how you would evaluate it and know if you are doing better. I was a participant in the 2005 Guideline Development Group and the more recent one. In 2005, we wrote chapters in advance and perhaps spent a week together making those chapters better and discussing the complexity of the evidence. Dorota described the 5-year process for the latest guidelines. Will the product be better? How will we know if it's better? What are we doing actually to assess these changes in methods? For the ISA, I was chair of CASAC at the time these changes began and were implemented. There was a clear gain in transparency from the prior criteria document and staff paper, certainly in transparency, but the methods have continued to evolve as lessons learned. How do we know if we're doing better? I would ask, is there something particular about air pollution and its challenges? Jennifer mentioned my question about what is air pollution. I would say that in part our research and our synthesis is directed by regulatory needs and expectations of policymakers. We've carved up air pollution into different components that match with the need for regulations and guidelines, particularly as they track back to sources. One size may not fit all here, and we're sometimes challenged to, quote, isolate or disentangle, as we say, the effects of one pollutant for what is in reality a highly complex mixture. PM, as David mentioned, is a great example. We treat it sometimes as a monolith when convenient, when in reality it is quite complex. The story for air pollution is going on in many other dimensions of environmental health and use of the findings of environmental research. There may be lessons learned from other systems that are evolving rapidly for chemicals, for example. One challenge, and probably worth discussing, is as decisions are made and stakeholders use the information, how important are the niceties that we have sometimes discussed in heated exchanges, the problems of grade or of any other system in dealing with the imperfect data, not only of epidemiology, but of the other scientific realms that are relevant to decision making. I think it's clear, and I think Kurt alluded to this, the system can be gamed. The other thought that I'll close with is, here what I'm going to term epidemiological exceptionalism. We seem to think that we have some special problems, and sometimes as a field, there's a response that might be described as having a chip on our collective shoulder. I think the problems here are perhaps more generic, and we move into this exceptionalism realm because sometimes the stakes are high. And when stakes are high, the level of criticism and comment is also probably appropriately strong. So let me in there, and I know we have much to discuss, and it's likely that this topic could be on the HEI annual meeting agenda permanently. Thanks.
So thanks very much, John. So I think Jennifer and me are going to take turns to ask a question. And if we could ask all the speakers and panelists to turn their videos and your microphones on. Question from Kurt: how can speakers, panelists ask questions? It seems you don't have that option. Hopefully we can reply to that fairly soon. But thanks for all the questions. I'm going to try and concentrate on the ones that are on the general principles of evidence synthesis rather than the specific ones about what's WHO going to do about a particular issue. But nevertheless, I'd like to start with this question, which was one of the first ones from Barbara Hoffman, and make it a bit more general. So her question is WHO planning to stay with the current grade adaptation and future guideline developments, or will WHO think about alternative approaches? So I'd like to ask Dorota to reply to that first, but maybe then the other two speakers and any other panelists who want to join in. And the more general question is, when you're doing evidence synthesis, where do you start? Because I think a lot of these debates are really a clash of cultures between essentially the Bradford Hill approach at one end and the grade approach at the other end. Do you start by just looking at everything and then deciding what the major issues are and what studies would help you to answer those? And it's something David Savitz has written about. Or do you start with something very precise like grade and Robbins and see where it takes you? And so, and as an epidemiologist, I think some of us are not very happy with some of the conclusions that are drawn using things like grade. And the question is it fixable, or do you need to start from somewhere else like Bradford Hill? So maybe I'll ask Dorota and Kurt and David to reply quickly first, and then see if any other panelists have any comments, and then I'll hand over to Jennifer for the next question. So Dorota.
Thank you very much. So for the question whether WHO will continue with grade or not, I'm as curious as all participants. But seriously, of course, we as a kind of a technical unit implementing the work, we adhere to the guidance given. For the time being, grade, to the best of my knowledge, stays. However, there is a very intensive discussion. There is a new unit dealing with the quality norms and standards, and there is discussion around the grade, its modifications and adjustments. So it is likely it will stay, but it's not the decision with us. But I hope that experiences like ours will be considered and will contribute to further guidance that we all can get when working on the future WHO guidelines. Thank you.
Thank you. Kurt?
Yeah, thank you. I'm also building up on that question and what also Dorota mentioned, that on how kind of time-consuming and intense the process was of adapting the tools for the systematic review. I'm currently also involved in another systematic review commissioned by WHO, and it is indeed extremely challenging. And there is often very different kind of understanding between some methodologists that try to impose the more rigid approach and the subject matter experts. And it's even more difficult than if, and there's several review teams, and we had kind of joint meetings when the other kind of members of other systematic review teams are not so experienced in systematic review methodology. They take for granted on what's being told to do. So I think this is a problem, and building on that and over to what Susan Norris said, and I think I agree with almost everything, if not everything, that Susan nicely summarized, including the different kind of strengths and weaknesses of grade, etc. But from there, I would like to come back to the question, what can we do to bring this back to a more kind of fit for purpose process? I don't think that the current approach to use the grade as it is and then to try to adapt it by experts for a specific setting is working. There's too many kind of principal pitfalls in the assessment of the certainty of the evidence for observational studies. How can we move forward strategically to improve the next tool by WHO?
Thanks. So for the speakers, please raise your electronic hand if you want to contribute to each question. I think I've got David Savitz, if you'd like to comment, and then John.
Very briefly, just to complement what Kurt was saying, I think that there's first of all, the good news is I think we've come to appreciate the art and science of evidence synthesis deserves attention in its own right. Historically, it had just been kind of, if you know how to do the research, you know how to put it together, and that is absolutely not true. I think, though, the only thing I would suggest is that groups like WHO or others consider whether to step back a bit and not just say, how do we tweak an algorithm, but to ask more broadly, how, and I don't have the answer, how do we put this evidence together in the most effective, thoughtful, informative way, allowing for things other than tweaking the upgrade, downgrade. The whole framework, I think, it would be good to step back and ask whether that's the most effective approach.
Thanks. So we have John and then Jason.
So just a quick comment, and going back to your starting point, Neil, I think it's important to distinguish evidence integration, which is the domain of Bradford Hill type criteria, and grade or other systems that are used for evidence synthesis, really the prelude to evidence integration. So I don't think we should oppose them. They are part really of a process that ideally should be integrated.
Thanks. Jason?
Yeah, I guess I kind of want to go back to, you asked the question, it's almost like a logistic question of how do you go about this process? And I think, the way that we've handled it in the ISAs over time is, we put a scope on the work that, on the types of studies we're looking for up front in the planning process, so at least provide some parameters around our literature search process. But even in that, we still at times end up with hundreds of thousands of papers, and then we got to figure out how do we dwindle down from there. And so I feel like we will tend to iterate on, okay, well, are there certain additional scoping parameters that we can put on this? In terms of the integration of evidence, we have a multidisciplinary team. So we have atmospheric chemists, we have experimental scientists, we have epidemiologists, we have folks that are experts in dosimetry, and all of them will individually go through and evaluate the science. And then we all come together at the end and figure out, well, how do we integrate this together? How do we tell the story of how all these lines of evidence fit together to ultimately result in some key science judgment, which ends for us is a causality determination.
Thanks. So I think there's no more hands up, so I'll hand over to Jennifer for the next question.
Thank you, Neil, and thank you, panelists. We had several questions come in concerning the role of exposure assessment in this process and in our consideration. Broadly, we heard there was a question for Dorota, your point about how the standards of quality differ between exposure assessment and epidemiology, and how that was problematic. So we could start there. And then we more broadly, we can talk about the role of exposure assessment in this consideration, in this process, given some of the limitations and the challenges that we have in exposure assessment, especially in air pollution epidemiology. So Dorota, we could start with you, and then we'll open it up to others in the panel.
Thank you. I wouldn't say that it's different standards of quality, but if I use the formulation which I recently was given by Joel Schwartz, when you talk to exposure scientists, we want to know the true exposure, activity patterns, etc. In epidemiological studies, what is really crucial is really getting a sense of what's the true unconfounded effect of the exposure. So measures of exposure and the assessment of the quality might be different. And this got us also to there was also a component of the reflection of the deficiencies in reporting in the studies to get more extensive information about how exposure assessment was conducted, what variables were included, and a more extensive reporting would be very much helpful then for the reviews of evidence and for drawing conclusions. So this was the observation which was also part of the discussion when the risk of bias tool was being developed in the context of the guidelines and this. So thank you.
Thank you, Dorota. And Kurt, I see you have your hand up. You have a comment?
Jennifer, I just on the exposure assessment, this was an issue that was largely extended and expanded in the latest update of the preamble to the IARC monographs, recognizing how important exposure assessment is. And other than often assumed all observational epidemiology is biased and is producing false positive results, often the exposure assessment leads to, not necessarily, but often to a bias that is towards the null, making it more difficult to kind of identify true associations and true effects. That's why we think that exposure assessment needs a careful attention. And while I strongly agree with John that there is the need for integration of the different streams of evidence, I think we all agree that we also need the subject matter experts, and here for the exposure assessment, it's the exposure experts that need to assess these. And I think this is important, and this then led for the IARC preamble, at least, over also to the issue of study sensitivity. So importance of exposure assessment assessed by the real experts.
Thank you, Kurt. All good points. And I think next we have Jason, and then we will go to David after that. So Jason.
Yeah, exposure assessment is extremely important when we're working on the ISAs. I mean, we have an entire chapter that's devoted to exposure assessment and then linking that to the results that we see within the epidemiology studies. And I think the way that the ISA is set up, it allows for that flexibility of having sections specifically devoted to the exposure assessment methods and then the epidemiology and linking it. I guess I have a question for Dorota of how did you handle in the air quality guidelines the fact that in many times the epidemiology studies themselves don't necessarily explain the exposure methods very well. And so you have to go one or two removed from the epi study to find the exposure assessment paper where it actually characterizes then the method that's used in the epi study.
Dorota, would you like to respond? You're muted.
Yes. Sorry. Yeah, this was one of the challenging tasks for the systematic review team to apply, and part of the challenges when developing the risk of bias instrument by the working group. So this has been elaborated, and the guidance was provided to the systematic review team so that this is reflected in the reviews. But yeah, this was one of the bigger challenges. Thank you.
Thank you. David, you had something to add?
Yeah, no, very briefly, I think that, this is an area where there's sort of a conventional approach that seems to be, there's variations on the theme, don't get me wrong, there's a little better, a little worse, and just to encourage the exploration of more radically different, they're going to be flawed as well, but differently flawed approaches. It just seems the traditions have become so entrenched. Bigger studies, a little more monitoring data, a little more better modeling and so on. But it just seems that it may be worthwhile to at least try to encourage some out of the box approaches.
Great, thank you for those comments. And John, you have something to add here.
Just a comment. I chaired the review for the National Academies of the approaches taken by EPA and the Toxic Substances Control Act of systematic review. And I think relevant and worth looking at was their effort to develop methods for systematically assessing, doing systematic review essentially of exposure data. And they were challenged to do so. And I think this is a general area where probably development is needed as a complement to the other areas where the methodologies for looking at investigations of environmental exposures are, I think, more robust and further along.
Thank you. The very nice discussion. Neil, I can turn it over to you for the next questions.
Okay, thanks. So there's several different questions that relate to study design. For example, there's one from Aaron Cohen, says, David advised against a focus on or hope for definitive studies. Could Kurt comment on the role of such studies in the IARC process? For example, air pollution and the NIOSH miners studies. Also, Jason, how do such studies play in the ISA? And then Chad Bailey asked about natural experiments, and Doug Brugger, I hope I've pronounced that correctly, asked about longer term RCTs and, for example, with the use of air filters, and shouldn't we promote more of this approach? So I guess the more general question, starting with Kurt, is how often is there a single definitive study, and how often should we aim for that? Or maybe we should be aiming for having several different approaches that are complementary. And so you might have a group of more definitive studies. And more generally, are we doing, particularly with regards to air pollution, are we doing the right sort of studies now, or is this something that we're really missing? Start with.
Okay, yeah, I'm happy that I can stay closer to air pollution and talking about diesel engine exhaust. So thank you, Aaron, for your question. I think we need to keep in mind that diesel engine exhaust for many years had been evaluated by IARC as limited evidence from the human epidemiology, meaning that there is a suggestive association, but chance bias confounding could not be ruled out. And I have carefully said when I talked about the NCI NIR study, a possibly influential study, but that doesn't mean that this is the one study that drives the evidence. I think it's always the idea of how consistent are the different findings from the different studies. Is there heterogeneity? Can it be explained? So rarely it's a one influential study that drives it out. For the diesel engine, I think exhaust study, this was certainly better than previous studies in terms of exposure assessment. It took care of some of the confounding issues, but I think there is not the one decisive study. It's really, and that brings me over to the related question on, say, natural experiments, etc. I think, and I have long presentations on that, that you always need to see the merit of a specific study in a specific context to answer a specific question. And we have had working groups that had a very strong consensus that for their setting, say arsenic in drinking water, which was a natural experiment, but studies were ecologic, that these ecologic studies were more informative than the analytical epidemiology. We have some group 1 carcinogens that have not been challenged that are based on case series. I think it really depends on the assessment of the specific context by the subject matter experts on what the respective study tells. That is my bottom line, and there is no hierarchy of studies.
Thanks, Kurt. We've got David and then Jason.
Yeah, again, sometimes like the diesel study, you can sort of have a brute force approach, just put more money into it, do the usual things with more rigor and care than the previous work, and that can be quite influential, but as Kurt said, every study still has quirks. I think very often the influential studies are often methodologic, where suddenly the right study can either corroborate a whole body of research that was you may have seen as vulnerable to a bias, but demonstrate it's absent, or conversely discover that they are all flawed and need to be downweighted. And having this sort of the studies that influence interpretation of a broader body of research are often the most informative.
Thanks, Jason.
Yeah, just to answer Aaron's question about how we consider those studies, it's along the lines of what Kurt was saying, that it's not one study. We're always stressing it's the broader body of evidence that's supporting the conclusions that we're making. I can't think of an instance or an example of where one study would materially change overall conclusions of 20, 30 years of research. It's always thinking about how does that fit into the broader body of evidence and whether it supports or refutes what we know already.
Thank you. So actually, just before I hand over to Jennifer, and we'll come back to Kurt in a moment, but Jennifer's pointed out that Savitz' question was, how would you characterize the role of findings based on causal inference methods in environmental epidemiology in judging the link between association and cause? So how useful are they? Maybe I'll go to David and then Kurt. Both to comment on that question and
sure. Again, very briefly, using the word does not help or hurt their value. More elaborate can be helpful sometimes, but I've always found it, maybe it's just a semantic issue. Every time I adjust for a confounder, I'm doing causal modeling. Why would I adjust for a confounder if I wasn't trying to get at a cause? And you can do that with varying degrees of elegance, but I really worry that the advertising of these are causal methods and the other ones are not, is a misrepresentation. It's a question of how effectively do they handle the key concerns.
Thanks. Jason?
Yeah, I was just basically going to reiterate what David said. I mean, that's the way that we've approached them. They're another line of evidence that, again, if they're instituting very elegant statistical methods, but it's another supporting line, and we don't view them as being a gold standard that provides additional information that's not garnered from some of the other studies that we've evaluated.
Thanks. Before I hand over to Jennifer, Kurt, you had your hand raised before?
That was an old hand raise.
Okay. So Jennifer, thanks.
Thank you. We have another question from Chris Bucock to the panel. And this one focuses on how to best communicate all of what we're talking about here in the panel to an audience such as policymakers. Obviously, there's a lot of subtleties and nuances in what we're talking about here, and what we arrive at may not be a simple yes or no answer. So how do we best communicate this to our various stakeholders? I could turn it over perhaps to anyone want to take this, or I can, Dorota or Kurt.
Jennifer, I'd like to hear from the policymakers and maybe a more honest sort of, I don't know, complaint, but what are epidemiologists not doing? And we're transmitting information, and I would assume that there is a frustration in the way it's presented in published material or articulated. But I think that we need to hear it again. I was saying from the demand-driven end of that. You know, what's lacking? What are we missing? I mean, Jason mentioned, for example, the details of exposure, or the, you know, I'd be curious though about other issues from the point of view of those who are using the data.
Any comments from Jason or Dorota on that point?
Sure. I mean, so I guess from experience of questions we often get from the policy office in terms of things missing or things they wish that we would present in the ISA or even in epidemiology studies in general. Obviously, one is, you know, a clear explanation of the exposure method that's used. And often that takes a little bit of digging at times, depending on how clearly that's articulated in the actual epidemiology study, or if we have to go find the original exposure study. Sometimes it's information on the distribution of air pollutant concentrations that directly factors into some of the decisions they make with respect to level of the standard. I think they're the two key ones that we get often over and over again. Another is, you know, how confident are we in, you know, the air pollutant health relationship, and down to what level? And so that's where I think a lot of the HEI funded low dose studies are really informing some of that information. They tend to be the three biggest questions that we get over and over again in the process of briefings and even just the development of the ISA itself.
Thank you, Jason. John, I see you have your hand raised.
So I think the word communicate is wrong. And I think the real question is, what are the pathways by which evidence figures into policymaking venues, and how does it track in? Sometimes we communicate in almost theatrical circumstances, like congressional testimony, which many of us have given. We participate in synthesis reports. We provide peer review to ISAs as scientists. So I think the real question is, what are the pathways by which information enters into these processes? What are the roles of the scientists who generated the original data, or the roles of those who synthesize it and try and put it into packages that we think will be useful? I think the word communicate applies. It's how do we show what we know and what we don't know. And I think, you know, Jason alluded to some of those ways that EPA might do this as an example.
Yeah, thank you for that point. Dorota, you're unmuted. Do you have a comment to add in here?
I maybe would very briefly build on what John said, that in fact, these are two aspects. One is really how the evidence makes it to the policy domain, where all these challenges really feature, and then communication, which you could say is at the other extreme. The end users want clear answer. They don't want to dig out into the details, but they want a communication that will really facilitate their action. So there is a challenge, I think, for the expert community to provide this clear message and then to communicate what's the context, what's the weight of this clear message, which is to support action made by the politician, and then these rigorous processes with all their deficiencies that we apply are a step to really ensure that the work is done as good as possible, and that this advice provided is really adequate and using the tools that are available. Thank you.
Thank you all for those comments. I can turn it over to Neil if you have an additional comment, questions from the audience.
Thanks. Hopefully we've got time for one last question. I think if there's one thing we've learned in the last year, it's that not all of the public trusts us experts. And there's a lot of skepticism about science. And so I think the debates we're having now, to some extent, they've been around for 40 years, but also they've evolved. And there's all sorts of pressures from all sides on regulatory committees. But it's, in my experience, you know, there's sort of two extremes. One is, you know, and I've been on committees like this or seen them where a bunch of us sit around and discuss the evidence for a couple of days and then basically just say, well, probably it does cause cancer, but we don't, it's not clear how we decided that, or probably it doesn't, or even worse, maybe it does, but the risk is probably fairly small, so we don't want to alarm the public. And it's just not clear how decisions are reached at. So are arrived at, and in response to that, it's tempting to have a very clear set of rules which anyone can follow. But then it's very clear to us that that doesn't always work very well for epidemiology either. So how do we get a system that works but have greater transparency in what we do, so that even if other scientists don't agree with our decisions, we can be very clear about how we arrived at them? David?
Yeah, no, again, in my alternative universe, sort of fantasy world, the research would be conveyed with utter objectivity and clarity, so that you would be saying that, well, we don't know, it's probably small if it's there. There would need to be the framing of that, but then a separate process for owning up to saying, given that, we're going to make this decision. And again, the part of it's a fantasy world, of course, is those who are in, you know, sort of in the spotlight for making the decision would like to be able to say the evidence forced it. It's unambiguous. It's absolute, as opposed to saying it might be the case in balance. We think it's better to do this than not. And so it's trying to sort of clarify that pathway. We've got some work to do, though, clearly.
Thanks. I see Kurt has his hand up and he'll comment on this question and have some final comments, and then we'll ask for any other speakers or panelists who wish to make a final comment, and then Anna has some final slides. So Kurt, first of all.
I'll try to be brief. Thanks, Neil. Regarding your point on making a transparent and simple kind of tool that everybody understands and can use, probably you didn't mean that, but I don't think that this is the idea, because this is often the tools that we criticize, risk of bias tools kind of developed by non-epidemiologists to be applied by epidemiologists. Essentially, there is a bias all over and the studies are not informative at all. It is interesting in that context, just last week, you may have heard, there was the first Nobel Prize Summit, and the Nobel Prize Summit also concluded with a statement signed by almost 100 Nobel Prize laureates. And in terms of the future and the decade for action, there were 7 proposals for planetary stewardship, and 2 are very close to our topic today. The one is...
So you've just frozen up, Kurt.
Oh, still? I can hear you, everything is fine?
Okay, you're okay, yeah, yep.
Okay. And so the first one was a strong emphasis on the nature of evidence, the scientific method and the scientific consensus to ensure that future populations have the grounding necessary to drive political and economic change. But also related to that was one on information technology and the big concern on amplification of misinformation, and that societies would urgently need to act to counter the industrialization of misinformation. This is from the Nobel laureate statement last week. And altogether, I think there is, at least from my perspective, a very strong consensus among the panelists here. But in my view, this consensus also includes the kind of critical perspective on the adaptation of grade to environmental health and public health in general. So the question really is, what would WHO and others do in trying to adapt the grade tools and the problematic parts, or is there not the need to reinvent? This is for me the bottom line, and that comes back to Barbara's first question. And I think this is where we need to think strategically. Thank you.
Thanks. So I shouldn't have asked the last question because we're running out of time. I'll just hand over to Jennifer, who I think will then hand back to Anna.
Yes, I think we can wrap up the session and thank all of our panelists for a wonderful discussion, and I'll hand it over to Anna.
Yep, thank you all. Can you see my slides? Okay,
Yep.
Great. So thank you to our chairs and our speakers. This was a wonderful, really informative session. Please come to our next webinar, which is next Tuesday. We also have an early career researcher spotlight and a final session about the low levels of exposure studies that HEI has funded that were referenced during this session. And then we are hopefully having an in-person conference next year. So April 24th, 26th in Washington, DC, please put that on your calendars. And thank you all. This has been a really wonderful session.
Thank you.
Thank you for organizing it.